I am Dr. Don Ravasio. I know I met some of you a month ago. Thank you for coming back. And for those of you that have not been here, welcome. This is meant to be just educational. It's a lot of fun. The question and answer session at the end is really, really informative, and I think that that's what you'll get the most out of. So if you have a question in your mind as we're going through this lecture, just kind of set it, write it down, jot it down on I think you all got a pen and some paper, and I'll be happy. I'll stay as long as I need to stay to answer all of your questions. That to me is the most benefit out of all of this. Again, I'm Dr. Ravasio. I grew up in Monongahela. I am Western Pennsylvania through and through. I was in the Army from 2003 to 2007. And then I went to UPMC Mercy, where I did trauma and joint replacements with UPMC. And then for the last 8 or 9 years, I was over at Canonsburg Hospital with AHN. I know some of you from there, some of my previous patients. And now I'm part of Washington Health System and very happy to be there doing total hips, total knees, general orthopedics, any of your orthopedic needs. So that's a little bit about my story. Today we're going to talk about your knees, not what they used to be. And I hear that all the time. My knees just aren't what they used to be, doc. So a little bit about orthopedic surgery. What is an orthopedic surgeon? Somebody with a lot of training in the care of muscles, tendons, joints, muscles. We provide both surgical and non-surgical care. Many different types of treatments. It could be oral anti-inflammatory medications, injections, obviously surgical treatments. I like to tell people sometimes that I feel like I'm nothing more than a glorified carpenter. You know what I mean? Your carpenters that build homes use all the same tools. They use hammers and chisels and nails, and that's kind of what we do in orthopedic surgery. And that's really what it is. It's in essence glorified carpentry. Although it took a lot of years to get to that glorified carpentry. So why does my knee hurt? Interesting that, this is a really good picture of just what happens with the progression of arthritis in your knee. And you can see that on the left you have a healthy knee. And you see this nice white shiny cartilage all up here in your knee, and there's no abnormalities whatsoever. It looks kind of pristine. That's what a healthy knee should look like. And then you look over here on the right and you see what happens as you start to develop progressive arthritis. The cartilage in your knee, which is this stuff, has started to thin out, and you all of a sudden start to find areas where there is no cartilage, or it starts to fray or crack or tear. And that's when, as things progress, you start to get what's called bone-on-bone arthritis, or I don't have any cartilage left in my knee. As arthritis progresses, all of that goes to that, and then it even becomes worse where you don't have any cartilage left at all. And the progression of that disease is really, really painful. People think, well, I just have some arthritis in my knee. Yeah, and that's easy to say, and it's easy to minimize. But arthritis is a painful disease process. There's no doubt about that. So what are some of the symptoms of arthritis in your knee? Chronic aches and pains, feeling of heat or swelling in the joint, certainly joint stiffness, or occasionally your joint might feel like it locks up. You can get sleep disruption. You can feel like you're developing bone spurs in your knee. And there's lots of different factors that contribute to the development of arthritis. Some of them you can control and some of them you can't. Obviously, there are some controllable factors like your level of activity, your body weight, things of that nature, but there's also some that you can't control. Genetics plays a role in the development of arthritis. Sometimes post-traumatic incidences where you may have really injured your knee when you were younger, 20 or 30 years ago, and now all of a sudden you're starting to develop a significant amount of arthritis in your knee. That, they can correlate to each other. So there are some things you can control, some things that you can't. And the other thing that you definitely can control, and that I implore you to, is to stay active. Because believe it or not, A lot of people have the misconception that too much activity when you have arthritis in your knees is a bad thing. That's not the case. So staying active and keeping your knees moving is a really important part of the treatment of arthritis because it helps your joint to produce normal, healthy joint fluid. It's like providing an oil change for your knee or lubrication for your knee. So keep your knees moving as much as you can, even as you move through the progressive stages of arthritic disease. So these numbers are old, but arthritis is by far and away the leading cause of disability among the elderly. That's not disputed. Nowadays, it's probably roughly 65 million adults in the United States that have doctor-diagnosed arthritis, which is basically almost 1 in 4. How do we diagnose arthritis? Various ways. Sometimes it's just as simple as you telling me your story, you telling me what you're feeling or what you're experiencing. Other times it may be, we have to get some x-rays to see what the stage of arthritis is that you have. Very rarely do we ever need like advanced imaging or blood work to make a diagnosis of arthritis, but in some circumstances we do, particularly with different kinds of arthritis. Like if we're talking about rheumatoid arthritis or psoriatic arthritis or one of the more atypical types of arthritis, sometimes it might take a little bit more of a diagnostic inquiry to figure out what that is. But the bottom line is it's the most common cause of disability in the United States by far and away. And again, this is just a slide showing that there's different types of arthritis, and these are the most common too. By far the most common is osteoarthritis, which is the one on the left. Rheumatoid arthritis is less common, but equally, if not more, is debilitating for anyone out there suffering from rheumatoid. From an orthopedic perspective, we don't treat them very differently, although it helps us to know one versus the other because it really helps us to figure out what you may be expecting with other joints down the road. So sometimes, like I said, osteoarthritis may just be limited to your knees, whereas if you have rheumatoid arthritis, it typically tends to affect multiple joints. So that's one of the reasons why sometimes we do spend the extra time trying to figure out what type of arthritis it is that you actually have. So women are at greater risk than men in the development of arthritis. Some of that is a hormonal thing. Delaying treatment can result in more serious knee problems going forward down the road. Women are 2 to 8 times more likely than men to have knee problems in general. And now it's pretty much over 750,000 knee replacements are performed yearly in the United States. I mean, that's a profound number when you think about that. I mean, so that just kind of shows you kind of like the global impact that arthritic disease has on our population. So what are some things that you can do as you go through this process of my knees just aren't what they used to be? Again, we talked a little bit about weight, and I'm just going to throw this out there. I'm a big guy too, so I'm never going to beat anybody up about their weight, I can promise you. But I can tell you that one of the take-home messages about weight is this. If I gain 10 pounds of body weight, that's actually the equivalent of about 20 pounds to my hips and about 40 pounds to my knees. And the reason for that is just our biomechanics, the way that our body works biomechanically. But the same is true when you lose. So if you were to lose even 10 pounds of body weight, that's the equivalent of taking about 40 pounds of weight off of your knees. So it has a profound impact on the overall health of your knees. And that's probably the last you'll hear me say about weight. So take it for what it is. It's a curse to a lot of people. But if you can manage a way to, and there are a lot of new ways now to lose weight, a lot of new medications out there that are helping people lose weight, it definitely will help the overall health of your joints. Exercise is what we touched on earlier. Please keep moving your joints in any fashion. Water is phenomenal for those of you that have a pool or can come here to Cameron and use the pools, because it's kind of like a non-weight-bearing way to exercise your joints. That's a great way to keep your joints moving without the pain of walking on concrete or walking on asphalt. Hot and cold compresses are great. Physical therapy is a blessing. I mean, those people, yes, by all means, people ask me all the time, if it was up to me, every one of my patients that gets joint replacements would go and see a physical therapist even before they have their knee replacement surgery. I get now, in this day and age, that insurance companies don't pay for that anymore, and that makes it more difficult. But if there is a way for you to do physical therapy prior to your joint replacement surgery, or even just for generalized motion and strengthening, if you're not considering having your joint replaced, that's the way to go. I mean, they're going to teach you things that you can do at home on your own that are going to be incredibly beneficial to you. So don't ever forget that avenue. So these are just some general treatments, non-surgical and surgical treatments that we use for the treatment of knee pain. Again, exercise, dietary supplements, physical therapy, sometimes shoe inserts, because sometimes foot and ankle problems can cause knee pain as well. Forget the immobilization and casting. That's kind of no longer being used unless we're dealing with something fractured. Walkers, canes, certainly joint injections are a good treatment option. And then surgical treatments, we still do arthroscopy, although we don't do arthroscopy much anymore for the treatment of arthritis itself. Some studies have come out in the past 5 to 10 years that basically show that it's just not effective. So why put you through a surgical procedure if it's not going to be of any long-term benefit to you? We do arthroscopy more, though, for things like tears in your knee. Meniscal tears, cruciate ligament tears, things like that. That's what arthroscopy is for. In terms of biologics, this is kind of a sensitive topic, and I'm just going to say this. There are a lot of orthopedic surgeons out there, and there are a couple that are even local, that love to make money. And you know what? I like to make money too, but I'm not going to do it unethically, and I'm not going to do it just for the sake of being able to charge you cash for a certain procedure. So there are things out there called platelet-rich plasma and stem cell injections, and some can cost $4,000 or $5,000 per pop. And I can tell you that your insurance is not going to pay for those things. And the longevity studies of those medicines have not proven out. But I will tell you, there are still people that will do them. And I think that it's a shame. So I'm just going to leave that at that. If there's somebody that has a specific question about PRP or stem cells you want to ask following the conclusion of the presentation, I'll be more than happy. That's one of my pet peeve topics. All right, so, and again, surgical treatments, partial knee replacements, total knee replacements. There are very limited indications for partial knee replacements, although I still do them. Many people in Western Pennsylvania still do them. It just has to be the right indication and the right patient to have a partial knee replacement done. What kind of things do we do for temporary relief? A lot of these, I'm sure many people in this room have already tried. Anti-inflammatory medications, Motrin, Advil, naproxen, Lodine, all those types of things. They all work to various degrees for different people. Injections, probably one of our go-to medications for the treatment of osteoarthritis in the knee is cortisone, or a steroid. And steroids kind of get a bad rap. I think that probably because sometimes they get overused, and that's not good, because too much of it can actually add to the destruction of your joint. But at least most of the people that I know in Western Pennsylvania will provide steroid injections for joint injections up to 4 times a year, which is roughly every 3 months, which is good because that kind of coincides with how long they usually last anyway. If they last less than that, then we tend to kind of move away from the steroids and on to other treatments. We also do things like, you may have heard of Synvisc or Euflexa or rooster comb, some people call it, or chicken shots, because the way that it was originally derived was from the comb of a rooster. That kind of is like a lubricant for the knee. It's a series of 3 injections that people get, and it basically helps to provide some additional lubrication to the inside of the knee. In the people that it works in, it's very effective. It'll give you approximately, a high percentage of relief. The downside is that it only works in about 65% of the patients that get it. The downside is there's no way to know it's going to work for you until you try. So that is an option. All right. So when should you consider surgery? I always tell people, come in and talk to me about getting treatment. If you are trying your typical things at home, your ice, your Advil, your Motrin, whatever it may be, modifying your activities, if you go through a week or 2 of that and you're still struggling to carry out your day-to-day activities through life, you should probably get checked. It doesn't mean you're going to need surgery. It just means that you may need something other than what you can do at home, right? So that may be the time where you may need to get a cortisone injection, or may be considered for the Euflexa injections. When pain continues day or night or prevents your sleep, that's a big one, because you got to sleep in order to be able to heal. And if you're not getting sleepful nights, that's a problem. When other treatments, such as physical therapy, don't relieve your pain. If you have harmful or unpleasant side effects from your medications. I guess the big picture of the slide is just don't live in pain. I mean, you have options that are available to you. Take advantage of them. Some of them you may like, some you may not like, but I think ultimately there are options out there for you to try to get some pain relief. Surgical solutions, we kind of touched on this a little bit earlier. Again, the limited indications for partial knee replacement. This is what a partial knee replacement looks like. You can see that, so this is the diseased knee like we showed you before. And in this particular instance, we just replaced one isolated part of the knee instead of the whole thing. So that would be a partial knee replacement. Total knee replacements, again, same idea, except for this time, the entire part of the leg bone, the entire part of the distal femur has been replaced with metal, and then there's a piece of plastic that fits in between. I'm going to pass this around. You guys can just take a look at this. You can't break it, so don't worry about it. But it basically shows you a knee replacement. This is the piece that would fit. These are plastic, obviously. We're not going to put plastic in your knee, but the knee replacements themselves are typically metal, made of either cobalt chromium or titanium. We cut the bone in such a fashion that the piece of the knee replacement then fits onto the end of the thigh bone, and then the same thing happens to the top of the leg bone. So we cut the appropriate cut on the top of the leg bone, and then the pieces fit together with that piece of plastic that's in between. You could just pass that around. So that's what a total knee replacement looks like. When, in considering total knee replacement, listen, I'd be the first one, I'd be lying to you if I told you that there is no surgery that's not without risk. None. Even the simplest carpal tunnel surgery or the simplest knee scope you can still get complications. That's just the nature of surgery, unfortunately. But we do our best to prevent those. We do our best to prevent, the ones that we worry about most with knee replacement surgery and any lower extremity surgery are blood clots and infection. So to prevent those in knee replacement patients, we make sure that you get antibiotics before your surgery, you get antibiotics after your surgery. To prevent the blood clots, you're going to go on a blood thinner for anywhere from 3 to 6 weeks, depending on your comorbidities and your history. So those are things that I as a surgeon take seriously, because if one of these things happen, it's going to significantly impact your ability to do your rehabilitation following the surgery. So we do everything we can, or everything in our power, to prevent those from happening. Okay? Again, those are potential risks. Again, infection and blood clots are the primary two. Leg length discrepancy and some of those other ones, that relates more toward total hip replacement than it does knee. It's a very successful surgery. I mean, I was just telling some friends before we started, if you would have told me 5 years ago that 60% of my knee replacements are actually going home on the day that they have their surgery, I would have just looked at you and laughed. I mean, but it's true. I mean, it literally has gotten to the point, because of some changes that we've been able to make preoperatively and during the course of the surgery, that people are literally able to have their surgery in the morning. They're up walking 90 minutes after they get out of the operating room. And then you're home to eat dinner at your own house, sleep in your own bed, with your own family members, and it's unreal. I never would have thought we would ever get to this point, but it really has gotten to that point. Now, again, that's not for everybody. Obviously, if you are, an elderly patient that has a history of heart disease or a history of blood clots or some other health thing that we may need to monitor in and around the time of your surgery, same-day surgery is not for you. But that definitely is going to be, for many people, especially people in their 50s and 60s that have bad joints, that's the way to go. It's definitely the way of the future, for sure. So 85 to 96% of knee implants last 20 years, and technology is continuously improving. Facts. Even better now, because that slide, I think, that's from the early, or 2013. The implants that I'm using now, although I'm not technically supposed to say, I'd be stunned if these things don't last 30 years. Just because the material that they're using now to make the implants is so much better. Again, significantly improved over 5 years ago. So that's definitely a good thing. What's this all about? It's about restoring your quality of life. This is just an example of one of the injections that I had mentioned earlier, like Synvisc or Euflexa. This is just another brand name of those medications. This is one of the upgrades that has happened in the last 5 years, is the development of vitamin E impregnated polyethylene. The little plastic piece that you're seeing in the knee replacement that's being passed around is actually infiltrated with vitamin E. And many of you may know or may not know, but vitamin E is a really potent antioxidant. And one of the problems that we've had with knee replacements in the past is that the oxidation process would tend to break down the plastic piece that fits in between the two metal pieces. So now the company that I use, at least, has come out with an antioxidant-filled piece of plastic so it doesn't break down anymore. And that's been a total game changer. So yeah, very good technology-wise. Trabecular metal technology is really good. We use this mostly in younger people that have really good bone quality. But in the elderly patients that get joint replacements, we tend to use cement to fix the knee replacement to the bone. In younger people, there's new technology now that the metal will actually grow into the bone without the need for cement. So it's really good, because sometimes with cement, you can get what's called loosening, or the cement bond to the bone can loosen, or it can come apart, and then something may need to be redone. But in younger people with this technology, that's also been a game changer. Personalized implants, precision surgery, proven technologies. There's so much new technology out now, I can't even begin to tell you. But there's another thing that we're going to be doing probably in the next 6 to 12 months where this little stem piece that goes down into the leg bone is actually going to provide data back to me as your surgeon that's going to allow me to track your recovery in terms of the progress that you're making with your range of motion, your gait, all kinds of different data analysis that's going to help me help you to improve better and faster. So there's so much new technology coming out that it's absolutely amazing. So recovery is a cooperative effort. What do I mean by that? I only half jokingly tell people that, my part in this process is literally like a 45-minute process. I mean, I'm going to bring you to the operating room. I'm going to put a knee replacement in your knee. And the reality of it is the rest is on you to make it work, because you have to be able to do the rehabilitation in order to make the knee function properly. So the biggest part of your recovery is your care team. And what I mean by that is that not just you, the patient, or me, the doctor, but your caregivers, the physical therapist that you choose to go to following your surgery, the nurse that's going to come to see you for the first couple of weeks after your surgery at the house, the home physical therapist that you're going to have. All of those people are going to contribute to the success of the procedure itself. Preparation facilitates better recovery. Having somebody at home, although it's not necessary, it definitely helps. What is the setup of your home? Do you live all on one floor? Do you have steps? All of those kinds of things make an impact on the kind of equipment that you might need to do your rehabilitation at home. And those are all things that we usually will talk to you about or take care of. Recovery starts immediately. So what do I mean by that? Well, like I was just explaining to you, for even if you end up staying in the hospital overnight and you're not going to be a same-day discharge, regardless, you're still going to be up walking the day you have your surgery. So it's gotten to be that profoundly different. When I started in this business 20 years ago, we did all of our knee replacements on a Monday. You know why? Because we couldn't discharge anybody until Friday. 5 days. You were in the hospital, you had IV pain medication, you had a Foley catheter, you had the whole 9 yards, and you were there for the week. Now it's so not like that. You don't have, that's why the surgical infection risk, everything has gone way down, because we figured out ways to make it better and safer for you, even if you do have to stay in the hospital overnight. Limitations after surgery, I jokingly say you don't have any, but obviously I don't want, nobody's going to go out and run a marathon afterwards. But the point is that it's okay to immediately start trying to resume your life after surgery. Again, you can't do too much, because if you do, I did a knee replacement a couple months ago on a guy. I love him to pieces, but I mean, he literally was out with a weed whacker like 8 or 10 days after he had his surgery done. Wouldn't you know it, he tripped in a hole and he kind of tweaked his knee a little bit. He's fine, but there's just certain things you probably shouldn't do maybe so quickly after surgery. But that just goes to show you how well people are doing now following their joint replacements. All right, so in summary, knee pain strikes millions of people every year. Don't delay your treatment. You're just keeping yourself in pain for no reason. There's new advances all the time that are helping people to restore their mobility and live pain-free. And success is definitely within your reach. Thank you. All right, so let's do some Q&A. This is my favorite part. How much is age a restriction? That's a great question. I can tell you that I've done knee replacements, unfortunately, on someone as young as 29 from a post-traumatic bad knee, and I've done knee replacements on somebody as old as 94. But I will tell you, that 94-year-old looked like she was 70 and acted like she was 70. So there's 94-year-olds that are 94, and there's 94-year-olds that are 70. So I've learned over the years that you can kind of just throw out chronological age. And I just, as a surgeon, you have to be able to tell through years of experience that certain older people are very amenable to having total knee arthroplasty done, especially as good as the procedure has gotten to be. But very good question. So the question is, I have a torn meniscus. Is that something that I should have treated, or and this young man is 70? So the question, it's a multifactorial answer. And the reason is that not everybody with a torn meniscus needs to have surgery, all right? But having said that, leaving a meniscus tear in your knee without treating it is probably eventually going to cause other problems in your knee. I don't have that slide back anymore, but the meniscus is like a shock absorber in your knee. And you have two of them, one on the inside, one on the outside. And when it tears, unfortunately, if it's left that way, it tends to further erode the articular cartilage in your knee, which the arthritis is already destroying. So if I were to venture a guess, in your knee, for example, you're 70, you probably have some arthritis in your knee. To what degree, I don't know. I would have to get an x-ray. But if I get an x-ray and I see that you already have arthritis in your knee, and then you come to me and say, I also have a meniscus tear, am I necessarily going to treat that meniscus tear? No. You know why? Because chances are you're going to end up needing a different surgery a little bit further down the road. And I personally am not going to put you through more than one procedure and scope your knee to just remove a tear in the meniscus when you may need to have something more extensive like a knee replacement down the road. I just think that's the wrong thing to do. So if by the counterpoint to that is if you came to me and said, I have a tear in my meniscus and you have no arthritis in your knee, 100% we're going to talk about doing a knee scope on your knee, because then we're going to prevent that arthritis from ever occurring or from progressing in your knee. So it really just depends on lots of factors. And I hope I made it somewhat simple for you to understand. But
So I should be laying?
I don't know. I don't know. I'd have to see x-rays of your knee. You know what I mean?
You showed me some.
So the question was basically, this young lady had a meniscus tear in her knee. She went to see an orthopedic surgeon and said her pain was coming from the meniscus tear. Another orthopedic surgeon told her that she has arthritis in the knee and the pain's coming from arthritis. There are definitely variances in the pain presentations of patients with meniscus problems versus arthritic problems. And I'll tell you just a couple that I kind of really heavily rely on. Patients with meniscus tears more often present with, I feel like something's wrong inside my knee. I feel like my knee is locking up, or my knee is giving out on me, or I feel like I have a mechanical problem in my knee. People with arthritic pain, basically the hallmark of arthritic pain is something called startup pain, meaning that you all are sitting here and after an hour of listening to me go on and on, you're going to get up out of your chairs and you're going to be like, ugh, my knee's freaking killing me right now. That's called startup pain. That is a definite hallmark of osteoarthritis or arthritic pain. There's no doubt about that. So there are different stories that can help you in your own mind sort out what is what, and things that I listen to as your doctor to try to help you come to the conclusion of, okay, well, you may have a meniscus tear, but man, that's not what's causing your symptoms. You know, I bet that it's probably the arthritis in your knee. Maybe let's try a shot of cortisone, or let's try some Synvisc or something like that and see, you know. And then listen, if we try the medication and it doesn't work, I'm wrong sometimes, you know, more than sometimes. But, you know, the reality of it is that it's a kind of a process in trying to figure out, you know, which is it? Is it the meniscus tear? Is it the arthritis? But there are ways. So the question is, if I have both, does that kind of point to a knee replacement? Definitely not necessarily. But again, if you have moderate arthritis or more, or severe arthritis with a meniscus tear, I'm not going to treat your meniscus tear. I am not. There are people out there that will be happy to scope your knee, but I can't find it in me to do that to you when I don't think it's really going to help you very much. So vitamin E is awesome. The question was, I have a question about vitamin E. Is that something that I should be taking? Vitamin E, if you noticed, in that piece of plastic, that's what we were just talking about, it's an antioxidant. I don't know that you need to necessarily take vitamin E by itself, but I 1000% would recommend that if you're over 65, you probably should think about maybe just taking a multivitamin that has vitamin E in it. I think that's probably more than enough. His question or kind of statement relates to the manner in which we fix joint replacements to the bone. And then in some patients, like I was saying, we use cement to fix the components to the bone. In other patients, we do what's called a press fit technique, where we basically just pound the hell out of the component into your bone, and over the course of the following 6 or 8 weeks, the bone will start to actually grow into the metal components. First of all, there are different ways. The question is, how can you get somebody up and walk if you're not using anything to definitively fix the implants into the knee? Well, the way that we insert them is something that's called press fit technique. And what that is basically, if I cut a bone and you have adequate bone quality, and I drill holes into that bone to put an implant in, we basically, the base of the implant is just a little bit bigger than the holes that we drill. Okay, you following me? So what ends up happening then, as we beat this implant into the bone, it's causing a really, really, really tight fit between the implant and the bone itself. That's how we can get away without using cement. But we can only do that in certain people. It has to be, your bone quality has to be of a certain caliber, and you have to be probably less than a certain age in most circumstances. So in my personal criteria, at minimum, you need to be under 65, and you need to have really, really good bone quality before I'll put a press fit knee into your knee. Because I have to rely on the fact, the last thing I want to do is have to bring you back to the operating room because, I decided not to put cement in your knee. But, I do it in people that I think in the long run it's going to be better for. So, but yes, your point is very valid that you would think intuitively you need to be concerned about having people get up and walk right away, but you don't. That's the best way to put it. So the question is, should I be using heat or ice for my knee? The general rule of thumb is that if you have an acute injury, and what I mean by that is something relatively new, ice is always the way to go, okay? Always the way to go. And in a patient with arthritic knee, that's not an acute problem. But if you go out and walk 5 miles on an arthritic knee, then you're kind of creating an acute process on something that's been there for a long time. So even in that circumstance, I would say you should still ice for a few days, and then you can go back to using heat, moist heat, Aspercreme, Bengay, whatever makes you feel better. People ask me all the time, which of these things? I always tell people, hey, you find whatever makes you feel better, and I'm all for it. I mean, I'm not prejudiced toward one or the other. You're going to use whatever works for you. But in the setting of acute pain or swelling following something that you just did, ice is always the way to go. Yeah, Voltaren is one of the classic. The question was, what about Voltaren? Voltaren is a classic anti-inflammatory medication. It works great. It is not for everybody. We got to remember, people that are on blood thinners especially cannot take those types of anti-inflammatory medications. So they're reserved, again, for certain people in certain circumstances, but it's a really good anti-inflammatory medication. Again, unfortunately, as your arthritis progresses, those types of medicines tend to lose their effect. All right, 66-year-old young lady who just recently had what sounds like Synvisc injections, which is like the lubricant type of medication. She unfortunately didn't get any relief from those medications. Like I told you, not an uncommon scenario. They only work statistically 65% of the time. Again, there's no way to know whether it's going to work for you until you try. She's asking, given the fact that they didn't work, can she now have a cortisone injection? And the answer is yes, of course. The reason is that they work in two totally different ways. You don't need to wait. I typically ask people to wait at least 6 weeks after they've had the series of 3 injections like Synvisc or Euflexa, because there are studies that show that there can be a delayed effect or a delayed benefit to those medicines. So I usually will tell people, wait at least 6 weeks. If you haven't gotten any relief out of that at all, then you can certainly come back in at that point and get a shot of cortisone in your knee. So the question is, if you have one knee replacement done, how long do you have to wait to have the second one done? It's going to depend on who you talk to. In my circumstance, again, depending on your overall health, in general, my answer is 4 months. Just because, the reason is because I want to make sure that literally you have a good leg to stand on when you go through round 2, right? You need to have that knee functioning at a high level in order for you to be able to do the rehabilitation on the other knee, right? Now, there are certain circumstances, and I don't think that it's going to apply to anybody in this room, because where I would consider, I'm still one of the few people that does bilateral knee replacements, and that's where we do both knees at the same time, but those are under exceptional circumstances. But in most people, you would have one done. At minimum, 4 months later, you would have the other one done. So what are my thoughts on knee pads? And so my answer to that is that I think there is benefit, because I think what you're referring to are the like knee sleeves, not just the pad where you would like kneel on your knee. Yeah, so the knee sleeves, the reason why they're beneficial is because if you remember way back, there's the fundamental treatment of joint pain and problem called RICE, which is rest, ice, compression, and elevation, right? So knee sleeves are part of that. They provide compression to the knee. Number one, they make you feel a little bit more secure whenever you're walking, maybe a little bit less unstable. And number two, they provide compression, which helps with the swelling in the joint. So do they have benefit? Yes, of course. Do I think there are some shysters out there that are trying to sell you a bill of goods? 1,000%. I think you probably could go to Walmart or CVS or even Amazon and just buy a good old compression knee sleeve for a fraction of the cost that some people are trying to sell them for you, and you'd be just as fine. So braces are a double-edged sword. Braces, in my opinion, are meant not to be used long-term, with the exception of the fact if you are not a surgical candidate. If you can't have surgery to fix the instability in your knee because of either other health issues or something going on, then yes, you should wear a brace, because ultimately our goal here is to keep you safe, right? Prevent you from having falls, things like that. In a healthier population, I personally don't like using bracing for no more than 3 months. And the reason why is because braces, by virtue of their design, inherently make your own ligaments weaker if you use them too much. You understand? So you have those metal bars that are running along the side of your knee, and they're there for a reason. But if you use it all the time, that external support is inherently going to take the pressure and the resistance off of your own ligaments and therefore make them weaker. So if you have a reason to wear the brace and you can't have anything done surgically to fix it, then wear the brace, because at least it's going to make you not fall. All right. But if you are having instability or weakness in your knee, then that's something you should talk to your orthopedic surgeon about. Yeah, so am I totally against stem cell replacements? Of course not. Stem cells can be a miraculous thing. But if you're getting stem cells with even a moderate degree of osteoarthritis in your knee, I'm telling you now, just write a check and give it to the Cameron Wellness Foundation, or send it to my kid's college scholarship foundation or something. I mean, it's just, you're wasting your money. I hate to say that. But does that mean that there are no indications for it? No, of course not. I think that it's going to be a game changer down the road, is once we identify what patients it's going to be good for and what patients it's not. But I've seen so many people, literally, I've had people come into my office literally in tears, crying that they've spent $10,000 on these injections for their knees, and I'm looking at their x-rays and I'm saying to myself, are you kidding me? You just have to be careful. Unfortunately, not everybody out there has your best interest at heart. They may have your wallet's best interest at heart, but they may not have you. So that's all that I'm saying. But are there indications for stem cell treatment? Yes. Are there indications for platelet-rich plasma injections? Yes. Some of which I do. If you have a torn rotator cuff and you're kind of maybe on the cusp of whether or not you need to have surgery, and we're thinking about maybe we can try some PRP. You know, that's not a bad option for you, because you're using your body's own blood products. You're injecting it into an area where it could potentially provide a better healing environment, or a bad Achilles tendonitis. I was just talking to Dr. Lowry, our foot and ankle doctor, about this the other day. I think there are certain foot and ankle conditions that respond really well to PRP. So there are indications for having these things done. But I would be very leery if somebody's offering that to you just for the treatment of arthritis alone. Okay, so the question is, does osteoporosis have any impact on your ability to get a knee replacement? Am I saying that right? Okay. So yes, of course. But does that preclude you from being able to get your knee replaced? No. In people that have severe degrees of osteoporosis, there are some things that I, as a surgeon, need to do differently in order to be able to do the knee replacement, but that's not going to preclude you from getting the knee replacement. So meniscus transplant's awesome technology, awesome surgery, not for your age. So 25, probably 30 years old at the max, I think. I know people getting them done. Turmeric is a very potent, natural type of anti-inflammatory medication. They sell it everywhere. I know several people that get it at Costco just because they get you a giant tub of it for cheap. But yeah, it's basically just a natural anti-inflammatory medication. Some people will sprinkle it in their cereal or whatever. Yeah, use it as directed on the container, and natural anti-inflammatory medicine. So no problems with it at all. The question was, I hear now that you're going to be affiliated with UPMC, and that is true. At least we think that it is. It obviously has to go through like the regulatory process. But from my personal opinion as a surgeon, I think that it's going to be great for the hospital, great for the community. You're going to have an increase in services. I think it's going to be, a win-win for everybody. All right. Hey, thank you all so much. Genuinely, I'm grateful you all came out, and I hope you learned something. And